Good afternoon, everybody. If you can all please take your seat, we're going to start that second part of the day, hoping that it's going to be as exciting as we had a session this morning. We've got pretty much the same formula. I'm going to be chairing the session. I'm Denis Bouchard from the Montreal Heart Institute. No, I do surgery for a living. And this is Anita Asgar, who was doing the live case of Tavi this morning. So we're going to have a live case. We're going to have a live in a box surgical demonstration as well. But we're going to start the session with Dr. Normand Racine, who's a cardiologist interested in heart failure, who's going to give us some of his idea of how to assess people with mitral valve regurgitation and heart failure as a heart team approach. Normand?
Merci, Denis. Thank you very much for the invitation. Like Denis said, I'm not an interventionist. I'm a heart failure and transplant specialist, but I do stimulate a lot of interventions, though. So my talk will be biased with the view of a heart failure specialist looking at patients who have mitral regurgitation. Here are my conflicts of interest. The learning objectives for the next 15 minutes. One is to review the recent advances in medical therapy in mitral regurgitation and heart failure, recognize the prognostic impact of mitral regurgitation in patients with heart failure, and recognize the major impact that this has, and as well as the specialized clinics that we have that can help our patients per se. To put this in perspective, just in the US, it's been described as there's more than 250,000 cases of significant MR diagnosed annually in the US. The current medical therapy are helpful to relieve symptoms, but we don't cure the patients. So we end up referring those patients for surgical repair or replacement. This is effective, but as you know, less than 20% of the patients are really referred for interventions. So there's clearly unmet needs for an effective therapy for those patients. What is the prevalence? For a 40-year-old patient, it's about 2%, but our population is getting older, and it's being described as being more than 10% in the population above 75 years old. The etiologies are multiple, but one which is rising quickly is heart failure associated with secondary functional MR. This is clearly, at the present time, underestimated, under-recognized, and has a dramatic impact on our population. So in fact, when we see those patients, do we really look at a mitral regurg patient, or we really see a patient who's short of breath, who has heart failure, but has combined mitral regurgitation? The prevalence of heart failure is about 2% for reduced EF, and it depends really on the studies that you look at. But if you want statistics that we have looked at this year in Quebec, there's about 175,000 patients walking in the street with that diagnosis. Of those, just barely 10,000 are followed in our 50 heart failure clinics. So you see there's a lot of patients walking in the street that we don't recognize or are not referred to our clinics. Of those, there's about 30,000 patients, new cases each year. So it's a huge number. And if you think that's a lot, it's going to increase by 38% over the next 15 years. So it's a disease that we need to recognize, not only heart failure, but those who have combined mitral regurgitation. Right now, every year, we hospitalize about 17,000 patients every year. And the cost for the government, for our Minister Barrette, is $123 million just for hospitalization per se in Quebec. So there's a lot we could do to improve those patients. Having said that, not all heart failure are created equal. So when we see those patients, obviously you look at the demographics, their age, you look at is it acute or is it chronic, is it preserved EF or lowered EF, what type of cardiomyopathy is it, ischemic, dilated, viral, familial, left bundle branch block, you look at those, the EF per se, do they have combined RV, LV dysfunction? Do they have valvular disease? Obviously, that's what we're going to talk about today. And comorbidities, diabetes, anemia, renal failure. We look also at markers for prognosis as well as those who have pulmonary hypertension. So the medical needs to be adapted to the type of patient that you see in front of you. So we need to evaluate them. A lot of education needs to be done, and that's where the best goals could be done in heart failure clinics. We need to optimize medical therapy according to the guidelines. And every year, the CCS publishes updated guidelines related to heart failure patients. This year, they came up with a heart failure compendium, which is really excellent. There's, like I said, about 50 heart failure clinics in Quebec, and I think we underutilize them. Then you have to consider other options for those patients. Do they need to be revascularized? Do they need an ICD? Should they have CRT? Valvular interventions, like I mentioned earlier. And then for those who are sicker, we have to look at ventricular assist device transplant and sometimes, obviously, palliative care. Briefly, we all know that therapy is effective for heart failure, ACE inhibitor being the first ones, a class 1 indication. And those are studies from Dr. Rouleau and colleagues published many years ago, which showed that ACE inhibitors reduce mortality with the SAFE trial. Other trials showed the same thing. Mortality was reduced by about 20%. Then came the ARBs. ARBs have shown to also reduce mortality. And finally, the new kid in the block is the combined renin-angiotensin blockade with a natriuretic peptide inhibitor, the neprilisine drug, which is LCZ 626, or what we call Entresto, which have been available in Quebec at least for the last few months. That came from the Paradigm heart failure trial that was published in the New England in 2014, where they compared LCZ 696 with enalapril, and what they found is that that new drug was better in reducing mortality, reducing heart failure, reducing combined events, compared to what was considered standard therapy. So the CCS came up with new recommendations based on this new drug. And what's important to remember, everybody, is that we have to optimize therapy, and that includes triple therapy. All heart failure patients with EF less than 40% should have ACE inhibitors or ARBs if they don't tolerate an ACE, but they also should have beta blockers, and they all should have MRA, which is our aldactone or Inspra or eplerenone. You need to push those drugs to the maximal dose tolerated. And after you've done that, if they're well stable, then you should consider switching the ACE or the ARB for Entresto or the LCZ 696. You should also consider CRTs and ICD depending if the patient's EF remains low or if they also have a combined left bundle branch block. Having said that, more specifically, I want to sensitize you that as soon as the EF is lowered, the prognosis goes down dramatically. Once you've dilated a patient who had an MI, who's got an EF of 45%, that patient is not going to do well in the long run. So we need to be aggressive with those patients with the medication and the follow-up. So patients with mild asymptomatic LV dysfunction with EF 40 to 50% have a mortality which is much higher than those who have a preserved EF. And obviously, the lower the ejection fraction, the higher the mortality. So that's one issue, the EF per se. Then the New York Heart Association class is also important. Class 2 have a better prognosis than class 3, and class 3 better than 4. Having said that, looking at the literature, you won't be able to find how many patients are class 1 or asymptomatic that we don't recognize at this time. Finally, MR. MR is a very strong prognostic marker of mortality in patients with heart failure. And this comes even from the SAFE trial, which, like I said, was published many years ago. About 20% of that cohort had mitral regurgitation. And as you can see, they had a much lower survival rate than those who did not have mitral regurgitation. Cardiovascular mortality was much higher, 2.4 times higher. Severe heart failure readmission was 1 times higher, and combined events, cardiovascular mortality, re-hospitalization for heart failure, or re-MI was 1.6 times higher. So someone with heart failure and mitral regurg, despite medical therapy, will have a much lower prognosis. So the presence of MR is a strong predictor. Having said that, there's others who have looked at, okay, once you've treated them as optimal as you can, what really can happen to those patients? Again, if you have mild versus moderate versus severe MR, you see on the panel on your left, panel A, you see that prognosis is definitely not the same. And the same thing for cardiac death. So cardiac death and all-cause mortality is higher as the severity of mitral regurg increases. Heart failure hospitalizations are much worse also, and you've seen earlier on how much this cost our system to hospitalize those patients. So if you know that your patient has heart failure and mitral regurg, one thing is nice to have optimal medical therapy, but you have to go further. You have to say, what else can we do? So if your patient has left bundle branch block, those are great patients who should be looked at for CRT implantation. And it's been well shown that CRT in heart failure patients with left bundle branch block reduces mortality, reduces heart failure hospitalization, and what we've also found is that it reduces mitral regurg in at least a third of the patients. So it's a one therapy that at least can alleviate or improve significantly mitral regurgitation with a CRT therapy. Once you've done that, you've done CRT, but the patient still has mitral regurg. This is another paper which showed that those patients who responded to CRT but have persistent mitral regurgitation, their prognosis is much worse once again. So what else could we do? So there's papers have been published lately in 2011 in JACC where they look at those specific patients. Heart failure, optimal therapy, mitral regurg despite CRT therapy, and what did they do? They implanted a mitral clip. And what you see on your left panel is that the New York Heart Association class was significantly improved in those patients who had a mitral clip. And the severity of mitral regurgitation, who was initially either grade 3 or grade 4 in all patients, was in majority of the cases only class 1 or grade 1 or grade 2 mitral regurg after a mitral clip. So mitral clip in patients with heart failure, CRT, optimal therapy, and persistent MR can do better if you did a mitral clip. So they concluded that about 70% of those patients did improve with this type of intervention. Now, the last issue is the issue of how do we take care of those patients. Once again, I just want to remind everybody that a multidisciplinary approach is really essential. Many papers have been published to that effect. This is one which looked at 30 trials where a team approach looked at those patients, and it's been well demonstrated that those patients have a much lower mortality, which is reduced by 21%. All-cause admission are reduced by 13%, and heart failure admissions are also reduced by 30%. So multidisciplinary heart failure clinics are, I think, essential for our patients. It's been well demonstrated that it's beneficial. And from then on, if those patients require other interventions, we can refer them to our colleagues, either EP guys for the CRT, ICDs, or our CAF people for the mitral clip. So in terms of interventional therapeutic options, what we do have available for our patients now, I've mentioned the mitral clip, which has been demonstrated beneficial. We also have mitral valve plasty or surgery in some of those patients. You also know that there are ongoing trials looking at transplanting cells. So cell therapy is being looked at in this group of patients now. Obviously, more and more of our patients are being approached with the idea of having LVAD being implanted. And finally, some of them will require heart transplantation. In conclusion, not all heart failure are created equal. Multiple markers exist to help you recognize those who have worse outcome. We need to optimize medical therapy. Like I said earlier on, the minimal triple therapy with ACE, beta blockers, and MRAs. If your patients have functional mitral regurgitation, it's well known that the risk of developing severe heart failure is threefold higher and twofold increased risk of death at 5 years. Functional MR has a prognostic implication which is potent in heart failure. Most patients at higher risk the groups that I've shown you, including patients with mitral regurgitation, should be considered for follow-up in heart failure clinic. And you should consider those patients in advanced heart failure programs where we could assess those patients and look at potential avenues, for example, MitraClip, VADs, or transplantation. I'll stop here. Thank you very much.